Is it the pharmacy industry, the indecision in Washington, our desires to do whatever is necessary to regain our health, or some combination of causes? The exploding cost of healthcare, tonight on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. When it comes to money, it is said you can't take it with you. But that doesn't mean you shouldn't spend it all before you die, especially on health care. We will discuss the drivers of increasing health care in the United States and what we might do about them. But first, let's take a look at this week's Prairie Doc quiz question. Former editor of the Journal of the American Medical Association, George Lundberg, has listed 8 reasons for a rising cost of health care and said the number one driver is because patients with insurance consider medical care as a freebie. Was Obamacare on that list as a cause? Yes or no? Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays originally written for this show comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in. But we answer your medical questions about health care costs the whole hour as they're called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us in the studio tonight is Dr. Jim Engelbrecht, retired rheumatologist and currently the Associate Medical Director at Dakota Care Insurance Company, part of Avera. And with us via Skype is Bob Doherty, Senior Vice President of Governmental Affairs and Public Policy for the American College of Physicians. He's based out of their office in Washington. Gentlemen, thank you.
Good evening.
Thank you both for joining us. Before we get started, I just kind of wanted, and with your encouragement, Jim, to talk about the cancer that I had. I was diagnosed October of 2016.
Let's talk a little bit about that.
Okay.
Since things are evolving. So it was about 11 months ago that we did the program where you and I switched places.
Yeah, you interviewed me about
this. You were the guest, and we talked about your cancer, which you've been very open about, and with pancreatic cancer and some of the general things there. The situation, just for the audience that's watching, is that you were diagnosed in October of 2016. You went through chemo, you went through some radiation, and then you were getting ready to do the Whipple procedure when we last talked. And the Whipple procedure is where everything is kind of removed, and it's a long recovery from that. But you went through that, and everything was looking great, and you got through that okay, went through the summer, been feeling fine, and so we just want to bring people up to date as to what's going on right now.
Right. Well, I had my 3-month checkup a couple weeks ago, and there's something in the liver.
Every 3 months
I've been getting an every 3 months CAT scan, and it looked good, clear, good, clear, good. CAT scan shows something in the liver. MRI confirmed that it was very suspicious, and the biopsy last Friday showed metastatic cancer. But it's a single lesion in the liver, and they sent the tissue off for precision testing, which means that we'll do genetics and a variety of different kinds of tests so that the real weaponry that we have for cancer we can better define with this special kind of testing. And if it does respond to the new chemo that I start tomorrow, then they will resect the liver lesion, because it seems to be, if it's a single lesion, it's the only lesion, they will cut it out, or they'll cut out the right lobe of the liver. So it's a setback. It leaves you thinking again about your impending death. I mean, we're all going to die, but I'm 69. I'd like to have a chance to meet my grandchildren, but it may not happen. I mean, but is that the worst thing in the world? No, probably the worst thing in the world is being married to me, and then, or maybe that's a good thing for her. But I'm not without hope. I've got a lot of hope, and we've got things to do. There's a good chance that it'll work. I'm going for that. I'm not afraid of what might happen if it doesn't work. And I've been surrounded by a lot of love. I've had a great life. It's been a wonderful run. You know, I've had this much life. If I went another 10 years, it would be this much more. If I lose that, well, I've still had this great life.
Right.
So enough on me. And
So we'll do an update again.
Yeah.
Once you know,
Yeah.
down the road a little bit, let's do an update again and,
Okay.
and bring the folks up to speed. But I just think it was a good place to start. And of course, you probably found firsthand that it's a little bit costly to get that level of care now.
well, a
There we go.
segue into the cost of health care. I will say this: the reason that I'm willing to do this, putting it out there, is not for the pity party or anything like that. But there are a lot of people who've had to struggle with these things.
Sure.
And I think if I can lend some support and help to them with this, as hospice director for my local hospice, you know, it's been a wonderful experience, and I think there's opening up. I would say one final thing, and we're going to go into the healthcare issue, and that is, to be afraid of death is dangerous to your health.
Yeah.
It is. So with that, let's dive into this. Now, I'm going to start with Bob. Tell us, Bob, a little bit about what you do.
Sure. I work in the Washington, D.C. office, the nation's capital, for the American College of Physicians, otherwise known as ACP. ACP is the largest physician specialty society in the United States, second largest physician membership organization, second only to AMA in total members, representing internal medicine physicians like Rick and Jim. And my job and the job of the staff in DC is to articulate for Congress and federal regulators the changes that physicians feel must be made in our healthcare system to make it more accessible, affordable, and of higher quality.
You know, and I have to say what an honor it is to have you, because I was on your public policy committee for several years. It was a joy to work with you and see your brain work. This is a brilliant man, everybody.
It's mutual. It's mutual.
It is a joy to have you here, and this is such a complex topic. There's probably no more difficult topic, and what we'd like to do is to make it simpler for people today so that they can understand this better and to make decisions and maybe even have some input into Washington in one way or another. Jim, now, why would I ask you, you're a rheumatologist, why would I ask you to be on the show about cost control?
Well, I think it's because as a rheumatologist, I was part of the problem. Okay, using expensive medicines on expensive diseases, and we could see firsthand what an impact that had and how that cost changed over the years. And concurrently with all that, I worked with the State Medical Association and at one point the AMA as AMA delegate, and became involved in some of the policy development, and then got involved with the insurance industry and sort of backed into it part-time, half-day, a week kind of thing, and started learning a little bit about medical directing. And I would get to see the side of the cost that the practicing physician doesn't always get to see, and then also some of the pharmacy issues that would come up in terms of the drug costs. And so, you know, I think that what you and I've shared over the years has been this experience where you've been part of some policy developments, but you've also been part of the actual practice of medicine as well as the administration of healthcare costs.
Right. So, you know, and you've done this for years and years. I mean, this working as an insurance person, looking at trying to control costs,
Right.
and as a physician, looking at the darn insurance company trying to control costs. So you've seen it from both sides.
Right. And I think that really allows you to kind of keep a perspective so that when policy things come down, you can sort of you can see it from both sides. So when Bob and the ACP folks or the AMA folks, you know, or the politicians come up with something, you can look at it from two different directions.
Two different directions. You know, there's an interesting article in the Journal of the American Medical Association this month, March 18th issue, where they not only showed some rather remarkable data, but they also had some editorials that were of interest. And they said that some of the reason for the health care cost is because of price. Now, the cost they showed was that about 18% of the United States' gross domestic product is spent on health care. And they compared in this article the 10 next most wealthy countries of the world and found that it was 9.5% gross domestic product in Australia, and it was the lowest of the next 10, and the highest of the next 10 was 12.5% in Switzerland. And we're 18%. So why is that? And they did a lot of looking at that.
I think Bob knows the answer to that, so we should ask Bob why.
Well, let's ask Bob. Bob, what's your? I was going to ask though first. Several months earlier, George Lundberg, who is the editor of the JAMA, of that journal, said the number one driver of health care is that patients see care as a freebie, and I used that in the quiz.
Right.
What responsibility does that put on the patient? So I guess I would put that question to you, Bob. Do you see that patient not looking to have value, not having to find value in healthcare? They see it as a freebie, as a major part of why healthcare costs so much?
Actually, I don't. And I would disagree with Dr. Lundberg on that. First of all, for most Americans, healthcare is anything but free. Over the last decade or so, we've moved into a system where more and more Americans have very high deductible healthcare plans. And that, by the way, predates Obamacare or the Affordable Care Act. Most Americans get their insurance from their employer, and employers paying their costs have been shifting more of the costs on their employees. And the way they do that is to impose higher deductibles where your insurance kicks in, higher copays, a percentage of the cost for a given procedure that the patient has to pay versus the insurance company. And they do other things like trying to restrict patients to narrow networks of physicians, so there's less choice of physicians, they have more control over the ordering of those physicians and the procedures they order, all those kind of things. So I think patients actually do skin in the game, maybe more than they should. The thing patients have no control over, in my view, is the price of health care. When they go to the hospital, say there's an emergency and they get hospitalized, and then if they discharge from the hospital, when they're discharged, they'll be faced with bills. And to decipher those bills, it's almost impossible. When my father passed away over 10 years ago, I'm allegedly a healthcare expert, and I couldn't make sense of the bill. The idea that patients can shop around, and particularly in an emergency situation or an urgent situation, to me is absurd. They're admitted to the hospital, and they have no control over what's being charged in the hospital. If you have a rare disease that can only be cured or treated by a particular specialty drug, you have no control as a patient over the cost of that drug. Even routine drugs that haven't changed very much in decades, like insulin, are seeing huge price increases. So I tend to believe that the number one driver of healthcare costs in the United States, and why we're more expensive than almost any other country, is simply the price of healthcare. We pay more for everything from hospital visits to chemotherapy to radiology, to just about everything, and more than any other country.
Jim, I'm going to toss it to you, and then we'll go to the Roland. But what's your response to that?
Well, I think I think there's something to that, but there's also a reason why some of that cost is so high for us is because we in fact do carry along some other countries. If you talk to physicians in some of the other countries, they will tell you officially or unofficially, we can do this because you guys are paying this for that, and so we get it for less, or so there's a little bit that we're carrying a bit of a load.
Pharmaceutical research.
But I also, and again, I'm not sure that it's seeing things as a freebie, but it also, but to me it's that people don't educate themselves enough about what their health care is all about, and they don't ask enough questions, and they don't query the doc about the costs and stuff. And I think Bob's absolutely right. You get an emergency situation, you end up in the emergency room, all of a sudden the charges are going crazy. You can't talk to anybody, but you have to think about those things ahead of time and figure out how you're going to approach the routine things and ask questions and be educated.
And when my wife Joni and I were talking about this at great length yesterday, she said, but we should educate the patients to know not to come in for the runny nose. I mean, don't come in. There's some things that you don't have to come in and see the doctor, and some of that stuff, if you've got it for free, you don't have to worry about it, they come in anyway. So it's certainly people could do better.
Yeah.
A doctor is pulled and pushed in many directions, especially when dealing with end-of-life care. How she or he reacts has an impact on costs.
Well, in my role as Chief Medical Officer for Avera, I can tell you that we are working very hard on healthcare reform already. So healthcare reform, in my mind, has begun. We have a long way to go, however. But I think when you look at the cost of healthcare in the United States today, in comparison to other countries, we spend way more than we should on healthcare. And so if we don't change that soon, number one, we won't be able to afford good care, and then we won't be able to get care to the people who really need it. So the question is, why is healthcare costs in the United States so much higher than the rest of the country? And as I thought about it, I really think it boils down to waste. It boils down to how we care for people, especially at the end stage of life. There's lots of data that support that 80% of the healthcare dollars that are spent on Medicare patients are spent in that last 6 months of life. That's a significant amount of spend. I think the other thing is just responsible ordering, choosing wisely, and I think too often physicians have been put in a position in which they're either asked by families or coerced to say, we need all these tests done, do everything that you can. And yet we know that some tests don't really help us with the diagnosis or in the treatment of the patient. And so I think, going forward, one of the ways that we can reduce costs is really taking a good look at that utilization and how we can choose more wisely what we order. So one of the questions that comes up is, what about physician liability? Aren't we just practicing defensive medicine? Does the cost of a potential lawsuit, make a difference in your decision regarding that patient? And I would say in a lot of states that's the case. We happen to live in South Dakota where there's a cap on that of those kinds of things, and so I think that helps to drive things down. I'd like to believe that my colleagues within Avera, can weigh that dilemma and make the right choice for the patient. I think some can do that well, but clearly some don't, and it becomes defensive medicine. I think families often drive physicians because they think that the MRI is the ultimate answer to the problem, and it not always is, and in fact, at times it can be wasteful. So I think if I had a picture that I would paint for the United States, it would be to follow South Dakota's lead and cap some of those damages.
This is your show, and your questions are key to the show discussion. So call in your questions or comments about healthcare costs. Comments are fine to 1-888-376-6225, or send us an email to ask@prairiedoc.org. Before we're getting some questions, thank you. But before we do that, I want to come back to doctors having a part of the responsibility here too. And if you're talking about overutilization, our doctor, every prescription is from the pen of a care provider. Every CAT scan is written as an order from a care provider. So,
well, I think that the doctors are caught a little bit because there is supposedly the standard of care, and if they don't do this test or that test or whatever, or miss something, and I think that it seems to be that students and the younger physicians are taught that there's something about, boy, we got to get to that diagnosis right now. Okay, so we got to do every test, because we got to get there right now. And when you and I were in training, I mean, it was more, let's talk to the patient, let's examine the patient. If we don't have it quite figured out, we'll check a couple of things. We'll do this for a week or two. We'll come back, back and recheck. If something changes, you call us. Mm-hmm. It was a more interactive kind of thing, as opposed to saying, gee, I got to do this scan, that scan. But and again, I understand some of that pressure because of liability issues and one thing and another. They're afraid that they're going to not see something, and then they're hanging out there. On the other side, the patients have responsibility to not run to the doctor every time they sneeze. They have to have some common sense and understand, that some things just will run its course, and a bad cold is a bad cold, and you take fluids and some chicken noodle soup and you wait it out.
Right.
Or
you take the vaccination.
And then you get your vaccinations, you get your flu shots, you get your other vaccinations on time, you wear helmets, you wear your seat belts, you avoid smoking cigarettes, and all of these things that you can do to make yourself go for a walk every day, go for a run every day, do some interval training every day, but do something, stay active, keep your mind active. All those things keep you out of the doctor's office. Bad things you did all the right things, and then something bad comes along. But then you got to deal with it,
we know that in the U.S. compared to the next wealthy countries of the world, 60% more CAT scans were performed, 38% more total knee replacement, 45% more MRIs, 32% more C-sections. I mean, these are overutilization issues. Yeah. And I believe, and I know Bob and I have had this conversation before, and we disagree. I believe that the culture in the emergency room, which is that same thing you're talking about, that drives physicians to do everything, is a threat of malpractice, and there's a huge influence. That threat, whether it's reduced or not, that threat is a real deal, and it pushes physicians to order more tests.
Well, I mean, defensive medicine, some people will play it down, but it's a very, very real thing. And I've been in the trenches long enough, 36 years of medical practice. I saw defensive medicine all the time.
But it's fair to ask Bob to respond, so I think this is the pro and the con. Let's hear your part of it, Bob.
Well, certainly I'm not going to take the con in terms of saying that defensive medicine doesn't exist and our crazy system where if mistakes are made, everybody runs to court and you try to get a settlement before a jury trial. It's very wasteful for the system. It's very frustrating for patients who really are harmed because often it's many years before there's a settlement. And it's very frustrating to physicians, of course, who are under this cloud of a malpractice suit. And they may have done nothing wrong, but it hurts their reputation and contributes to physician burnout, which could be another whole topic we just could discuss at some point.
Right.
So I do believe that defensive medicine is a factor in healthcare costs. Where I maybe disagree is how big a factor is. And I look at evidence. I look at studies. Because if I'm going to go to Congress, I've got to give them the most persuasive data I can find. And the data I have seen suggests that it is a factor, not an insignificant factor, but there are far greater contributors to the healthcare cost crisis in the United States. And if you want to sort of simplify what's driving healthcare costs, we're sort of talking about, like, on one hand, we do too much unnecessary testing, too much waste, and that's clearly correct. Yeah. But the other part is the price. What are healthcare costs? It's number of things you do multiplied by the cost of the things you are doing. So if you're doing too many MRIs, that's going to drive a cost. But if the price of that MRI is higher, the cost is going to be higher. So we really have to look at both parts of that equation. Why is there excess ordering, excess utilization, so much waste in the system? And then we have to look about is why is the unit pricing for those things that doctors are ordering much higher than in other countries?
Well, and you can even carry that to the pharmacy, the price of the drugs that we purchase. In that, oh yeah.
Well, no, I was just going to say to ask Bob, and from a policy standpoint, what is your sense of the whole concept of HSAs and putting HSAs into a more prominent position of putting people, getting people catastrophic insurance, lowering the premiums, let them be
value
responsible for the first dollar stuff for more, forcing themselves to become educated about some of this stuff. I mean, it was kind of.
So explain an HSA to the public.
Health savings account, and so it's a you buy a basic catastrophic policy, which is relatively cheap.
Everything above $5,000 or $10,000.
$5,000 or whatever what you're saying is that it's kind of like buying your house insurance, okay? I mean, you're not, you don't want them to, cover painting your house and putting shingles on it. But if your house burns down, you'd like a new house. So it's the same thing with catastrophic. This is how much risk I can tolerate. I don't want to get blown out of the water, though. After $5,000 or $10,000, I don't want that. And so
and the savings account part of it is.
And then the savings account is the difference between what you ordinarily would be paying for the premium if you had a full thing, and what this catastrophic policy costs, and you set that aside in an account that then can accrue. And if the healthier you stay, the more money that you accrue.
Plus it makes you looking for value.
You're looking for value because you're spending your dollars. And I know there's a debate, and this was a strong part of the AMA reform package prior to Obamacare, and then it kind of got jettisoned with the Obamacare thing. It was not a prominent thing.
Right. Well, it didn't take over.
The question is, for Bob, should that be coming back a little bit now, or is it coming back a little bit now, or is that a good thing, or what's the ACP position on that?
Yeah, what do you think about health savings?
Yeah, it's a good question. The ACP position, I can tell you, is that for some people, pre-funding the health care through health savings accounts with a wraparound higher deductible plan can be a good option, and it should be among the options that are available to people. Having said that, there are some downsides with HSAs. HSAs benefit those who are higher income more than they are than the lower income, because they use what's called pre-tax dollars. So you're not taxed on that. If you're a poor person, for one thing, you don't usually have the resources to put into a savings account for your health care when you're having trouble paying the rent and paying for groceries and paying for childcare for your kids. So they don't really have the disposable income to do that. And the tax benefit, if they did, is much lower than for higher income people. The other thing I would point out is that most of the healthcare costs in this country, and we talked about this in the segment on end-of-life care, are generated by people who are very sick. They're in their last year or so of life, or they're patients who maybe have many years ahead of them, but have multiple chronic diseases, all at the same time. Those people will go through their HSAs in a heartbeat, no pun intended, because their cost of care is so high, they'll run through the HSA, and they'll be in the high deductible plan, the wraparound at that point. So for those really high-cost people that generate so much of our healthcare expense, I don't see that HSAs are going to do much except in the margins for some people.
Right.
There's some data out there that something like this 5% of patients generate some enormous percentage of the whole overall healthcare bill, and those patients tend to be people who are very sick.
Well, those are.
I was going to say, and I think that you touched on one thing, though, that having an HSA plan available in sort of the cafeteria or the buffet that you're going into to choose plans would be an important thing, just the same as being able to define what you need for coverage.
Right.
Okay. I mean, one of the flaws I think in the Obamacare thing was that it defined what this package of coverage was, and everybody had to buy the same thing. And everybody didn't need maternity coverage, or everybody didn't need. I mean, so it would seem to me that it'd be interesting experiment to allow plans to be sold online where you could actually go in and design a plan that fits you.
Right.
You know, whether it involved an HSA or didn't. The other thing with HSAs and poorer people that don't have the income would be, you know, you could maybe supplement those people and give them some vouchers that they could then either save or put in their you know, I mean, it would.
There'd be ways to make it work. We touched on Obamacare. We're past the 10 minutes. Bob, what do you think about, you know, I know that Obamacare helped cover people who didn't have coverage before. Give me 2 or 3 sentences about what you think Obamacare, the Obamacare ACA did to help people or not.
No, I think it has been enormous help. It has driven down the uninsured rate to the lowest ever in the United States history.
I see.
More than 9 out of 10 Americans now have health insurance, largely because of the ACA. For people with pre-existing conditions, they can no longer be turned down for health care. They can no longer put lifetime limits on your coverage. All these things have helped millions and millions and millions of Americans. It's not perfect. It needs to be improved, but it's been an enormous help to people. And I have to respectfully disagree with Jim on this idea that people should just pick and choose their benefits. The 10 essential benefits that Obamacare requires be offered are things that any insurance should offer. Doctor visits, chemotherapy, prescription drugs, hospital visits, pediatric visits. These aren't nice things that it would be great to have. These are things that are what health insurance should be all about. Because if you don't have those things and you get sick, then you're in a world of hurt. And somebody else will end up paying for it because you're still going to get the care, but somebody else will be paying for it. And even the example of maternity, I'm a 60-year-old, 2-year-old male. My kids are grown. You know, I don't need maternity coverage. My family does it. But in my workplace, we've got young women in my office who are having babies. I am helping to subsidize them through my employer-based coverage, just like they're going to help subsidize old man diseases that people of my age get, the prostate cancer, things like that. That's the way health insurance works, cross-subsidization.
Yeah. You said that we have almost 90% covered by insurance. What was the number that we had before Obamacare that were not covered? So we're 10% not covered now. How many before?
Yeah, it was in the low 80s. It was about low 80s.
So it increased it up to 90%. But do you know that the article in the JAMA showed that the next 10 countries had 99 to 100% covered. And we were the worst covered. And the other thing that was interesting in that study was that it showed that there was great wealth disparity in the U.S. than in the next 10 countries, that we have many more poor people here. So that was distressing. I do need to get to questions.
All right.
We have a Sioux Falls woman wonders, why do increasing numbers of insurance companies insist we buy our meds with express pharmacy rather than local pharmacies? Jim?
It's just it's dollars and cents. I mean, wherever they have the best, most cost-effective way to get it. I mean, I don't agree with that necessarily. I mean, I think local pharmacies ought to be given a shot, and local pharmacies can band together and you know, but you know, it basically comes down to this drug from on the express basis. If you send in the thing, they get it for so much, and if you do it locally, it's so much more. And that's
they've made a deal with Express Scripts.
Yep. Well, not Express Scripts, but they're talking about Express Pharmacy.
Express Pharmacy, yep. Okay. Well, why are drug prices so high in the United States when compared to other countries? Let's take that one on right now.
Drug prices in the United States versus other countries, them being higher, the short answer, the simple answer is just simply because there's nothing stopping them. Most countries have some way of putting in price controls, negotiating set prices. By the way our patent system works, our government really allows drug manufacturers to almost create a monopoly. So when they discover or bring a new drug to market, they have a 20-year patent on that medication. When that patent's intact, they're the only ones allowed to sell that medication. There can't be generic medications or other drug companies that bring that drug to market. And then to make matters worse, drug companies have gotten pretty good at changing something very simple, maybe the coding of the medication or making it long-acting or combining it with another medication to even extend that patent longer. as consumers, our drug plans have really changed. Our health plans have really changed. More of our health plans have higher deductibles. They have higher copays. They have more strict formularies, which is really, in essence, a list of medications they'll cover and at what price. Does the pharmaceutical industry have influence in Washington? Absolutely. It's the largest lobby by far. If you go back to, about 2003, 2004, when Medicare Part D got approved, which is the drug coverage part of our Medicare program, at that time, there was thoughts about putting the ability to negotiate drugs, and Big Pharma really kind of convinced the legislators that that was price control, which obviously, historically speaking, we try to avoid price control and really rely on a free market system. Should pharmaceutical manufacturers base their decisions on the same ethics as providers, whether that's physicians or pharmacists or nurses or practitioners or PAs or whatever it might be? Absolutely. At the end of the day, healthcare is something that we need to do what's best for the patient. I think oftentimes you look at our pharmaceutical manufacturers, and they're publicly traded companies. They have profit margins they need to hit. They have shareholders that they're ultimately held responsible. I think oftentimes you look at our pharmaceutical manufacturers, and they're publicly traded companies. They have profit margins they need to hit. I think just overall thoughts, as a patient, it's important for you to communicate with your physician, communicate with your pharmacist, ask about generic drugs. Generic medications are quite a bit cheaper. Don't be afraid to ask if there's alternatives available.
That issue of cost of drugs just blows me out of the water, that it is so expensive. I know that from one of the editorials in that JAMA issue, they looked at the price of drugs in the U.S. for the same drugs in Europe and the next wealthy countries, and for every dollar they spend there, we spend $2.50 here for the same drug. And if we look at the price of angioplasties, there's just we don't overdo angioplasties. We do the same amount per capita as they do in the rest of these countries, but it's for every $1 for the angioplasty here or there, it's $5.25 here. The prices are just so why?
So what's your answer? What's your answer? You want to put price controls on everything and lock them down? And is that what the answer is? I mean, what's the ACP say?
What does the ACP say?
Well, we actually have published a comprehensive policy paper on how to control prescription drug prices. And like any of these issues, it's not one single thing. One answer is to stop drug companies from abusing the patent process, the exclusivity, to keep competitors off the market longer than they should. The way it works is pharmaceuticals, when they develop a new drug, and a lot of them never come to market because they fail in testing clinical trials. But when it comes to market, they get a period of exclusivity where nobody can manufacture a competitor or a generic competitor, which is good. There needs to be some of that protection. But what those sometimes do is change one molecule or make a small change in the drug that doesn't change its clinical effectiveness and use that to extend their exclusive rights over that. So that is anti-competitive. And if you believe in a free market economy, everybody should be opposed to abusing the exclusivity for that reason. I do think there's a role for the federal government to negotiate prices. I wouldn't say set prices. The Veterans Administration, the VA system, they negotiate prices. Medicare by law is prohibited for negotiating the price of drugs. I do think that needs to be changed. And things like California law, the drug industry says that, well, we can justify our price increases by research and development. And what the California law says, okay, if that's the case, show us. If you're going to raise the price, show us how much of that is due to R&D and how much of it is due to other things, such as generating higher profit margins. I think that can be part of the solution. So like many of these issues, it's a multifaceted approach, but I think the key things I work on are the exclusivity issue, the abuse of that, more transparency in terms of the pricing of drugs, and also abuse of where somebody buys a patent for an existing drug, so there's no new R&D costs, and then jack up the price, which I think is ridiculous.
Yeah, and we know that 20% profit is across the board. I mean, you're no friend of pharmacy either. I mean, you and I have had a long conversation.
We've had a lot of conversations about that, and I think that the increasing the competition is huge. I think you have to have, if you're going to have the research, you've got to have some way to
pay back for the
costs
research,
and pay. That's got to be factored in. I think that physicians sometimes are choosing the more expensive drugs because they think it's the latest, slickest deal,
yep.
and you can do it cheaper. So they bear some responsibility in this. I mean, there's a lot of ways to get at this, point by point, without just saying, okay, well, we're going to do price controls, and all of a sudden we have no advances.
Yeah, I'm ticked right now because I went to my pharmacy to pick up an anti-nausea drug for the chemotherapy I'm going to start, and the insurance company won't pay for it. And it used to be a $2 or $3 drug. It's up to 40 now.
Yeah.
And the Creon that I take, some insurance company proved that it worked. Well, we knew it worked, but they proved that it worked, so they got the patent, and so it's $850, $900 for a month's supply instead of the $20 it used to be. It burns my bottom on that one, I can tell you. We've got some questions. Thank you. Man from Madison, South Dakota has a CPAP machine, recently got a new hose and tank. Why is it so expensive? Jim?
Well,
the price will bear.
It's whatever from an insurance perspective, we will pay X amount of dollars, and we have a contract with that durable goods equipment person to say, if you give them a CPAP hose, this is what we pay, and they've signed a contract, and that's what they'll take. And so that's, that it's all.
So it's cheaper to the insurance company, but the guy who has to pay for
well,
it.
Well, but if he has our insurance, then he goes and gets his CPAP hose, and we pay for it, and we pay X price. Now, if he just goes down and buy a CPAP hose, he might pay $20 or $50, and we're paying 10.
Right, there it is. From Facebook, thank you for Facebook. Is the lack of competition for hospital care West River causes the higher price? Jim, I'll ask you that too. West River prices, hospital care is high. Is it the lack of competition?
I live in West River, so I have to be careful what I say.
Yes, that's you. That's your home.
That's right. So, I think whenever you're in a situation where there's no competition, you run the risk of having higher costs. And I know of specific incidents, specific cases where the exact same thing in a big competitive market like the Twin Cities or in Denver or a big competitive market was X amount of dollars, and when it was done in a smaller market or in a market like West River or even smaller markets, it was 2 or 3 times more.
Right.
And so, that's, and I don't know how to get to the bottom of that,
yeah.
but that is an issue, where you have no competition. People can kind of just set it and say, well, that's what the rate is, and then if you don't,
A lot of people will say it's a bad thing that we have Sanford Hospital and Avera Hospital in Sioux Falls, and I say it's a good thing. It's brought up the quality. It's reduced. It's at least controlled some of the costs.
Listen, they make each other better. They make each other cost effective.
Yep.
It's
a good thing.
It is a good thing.
A man from Brookings has an elderly mother on Medicare and supplement. Her flu shot costs $250. Insurance paid in full. Our health care wouldn't be in the shape it is right now if high prices were not so inflated through insurance companies. Would you elaborate on the issue? And he's saying it's the insurance companies that cause it to be elevated. I'm going to throw this very question out to the two of you very quickly answer this. So the prices are sky high. What would be one thing that we could do right away, or our government could do, to change the prices? Bob?
Well, I would probably start with just drug pricing. And because that is one where there is huge bipartisan agreement that something needs to be done. President Trump, in his State of the Union address, promised to bring down the prices of drugs, negotiate better deals for people than what we're currently getting. And that's not to let doctors or hospitals or others off the hook, by no means. But unlike the physicians community or hospitals, which actually are regulated, Medicare regulates the prices charged by hospitals. They regulate the prices charged by doctors. The pharmaceutical industry has really been the only sector that is largely unregulated in terms of pricing.
Okay.
So I would start there. I think we could make enormous strides if we could agree on some bipartisan bills to stop abuse of the patent process, to keep competitors off the market, to require greater transparency when prices are raised, and to deal with other abuses that are allowing the industry to jack up prices in a way that really is not justifiable by the research and development costs involved.
All right, Jim?
I would agree with drugs and this patent process and some of the things that have been done there, twisting molecules around and one thing or another. I mean, to get competition in the drug world would be, I mean, to improve that, exactly what Bob says, I agree with 100%, that would be helpful.
I feel like one of the problems with U.S. healthcare is a lack of coordinated care, especially holistic care. So coordination of care, what do you think of that?
Well, I think that you know, a lot of the insurance companies are taking over that coordination of care because coordinated care is more efficient, more cost-effective care.
And better for the patient.
Well, it's better for the patient, but you know, the thing at Dakota Care and Avera, I mean, we look at ourselves, whether you're the UM nurses or the medical management people in general or the medical directors, we're looking at being an advocate for both the patient and for the physicians, so we can get the most cost-effective result. And I think that, you know, that involves coordination of care. That's why we have case managers and all those kinds of things.
All right, 20 seconds to you, Bob. The last word.
I think coordination care is absolutely essential. And this is one area that's good news. Congress, as part of its bipartisan budget deal about a month ago, passed a whole package of legislation to reduce barriers to coordination of care for patients with chronic disease, to test new innovation models, to make sure that information is shared freely, to encourage use of telemedicine, to get information to the patient from a remote physician. So there's some really positive developments in that regard.
Thank you, Bob. Thank you, Jim. And now for the winner of tonight's Prairie Doc quiz question. The former editor of the JAMA, George Lundberg, has listed 8 reasons for rising cost of health care and said the #1 driver is because patients with insurance consider medical care as a freebie. Was Obamacare on the list as a cause? Yes or no? The answer is no. It was not a cause for the increased health care costs. It was Cheryl Reeds, who answered the question correctly. Thank you, Cheryl, for participating. Forgive me for saying your last name. And a book will be in the mail to you soon. We'll be right back after this.
Because you don't want to miss out on the little things. Because you want to be there for life's important milestones. There are many reasons to get life-saving cancer screenings. More than 4,000 women die each year from cervical cancer. But regular screenings can prevent this cancer and catch it early. Do it for the people you love.
Promise?
Promise.
Promise. Promise. Promise.
Make the promise to get screened. For more information about life-saving screenings or available financial assistance, visit getscreenedsd.org.
Economists often explain high healthcare costs by comparing the purchasing of food at the grocery store when someone else is paying. The metaphor still works, but with a twist. Reported in a recent medical journal, Harvard researchers looked at healthcare spending here in comparison to the 10 next highest income countries of the world. They found that in 2016, we spent almost 18% of our gross domestic product on healthcare, while in the other 10 countries, spending was much less, ranging from 9.5% in Australia to 12.5% in Switzerland. That's a lot of difference. Most surprising was that the problem in the U.S. did not appear to be from overutilization, getting too much care. Here, patients saw the doctor and were sent to the hospital in about the same frequency as in other nations. While the study found in the U.S. an overuse of expensive image testing and many more specific surgical procedures, like 60% more CT scans performed than the average of the other countries, 45% more MRIs, 38% more total knees, and 32% more C-sections, still, these accounted for only a small part of the difference in spending. That said, we did send people home from the hospital a little sooner in the U.S. Overall, in the utilization of hospital and outpatient care was about the same as in the other 10 countries, and so was the overall quality of the care. The study group also noted our ratio of primary care doctors versus specialists and referral rates about the same as other rich countries. The rate of poverty was found to be higher in the US than in other wealthy nations, and only 90% of our people were insured compared to 99 to 100% in all the other 10 countries. Those are big problems and could explain a partial cause for the high cost of health care here. However, the research suggested that higher US spending stems mostly from the complexity of our payment system. This has resulted in high administrative costs, 8% GDP versus 3%. The higher price of hospitalizations, doctor's visits, as well as the price of drugs here. Going after overutilization will likely not help much. It would be like going to our grocery store and finding the cost of milk is twice as high as the store on the other side of town, because payment for milk here requires bargaining between an insurance company, the government, the dairy, and the grocery store. It's time to simplify. Go to Facebook and we'll be live. You can finish up our questions there. A big thank you to our guests, Bob Doherty and Jim Engelbrecht. Thank you both for joining us tonight and discussing this important, difficult, challenging problem of healthcare. It isn't over yet, folks. While the biggest part of flu season seems to have passed and influenza A is declining, we're seeing a second wave of the flu virus with an increase of influenza B. According to the Centers for Disease Control, nearly 58% of all confirmed cases of the flu now were caused by the B strain. This B strain tends to be more severe in younger children. So keep washing your hands, cover your cough, try to avoid close exposure to those who are ill. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
So your kids have grown and your nest is empty. But wait, suddenly there's the sound of a new pitter-pat of feet in your house. What has changed since you raised your children? Caring for your grandchildren. Next time, On Call with the Prairie Doc.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota, and with the ongoing support of these individuals and institutions: Brookings Health System, Ophthalmology Limited, American Academy of Family Physicians Foundation and South Dakota Academy of Family Physicians, Avera Heart Hospital, Dakota Allergy and Asthma, CoBank, Fishback Financial Corporation, Vance Thompson Vision, Aberdeen District Medical Society, Black Hills Medical Society, 3rd District Medical Society Brookings, Madison, and Flandreau, Dakota Bank, Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, and Swiftel Communications.